Hello. Thank you all for joining us today and welcome back. I hope you had a refreshing break from the PFD Forum. So we're excited to begin our second session of the 2025 CDTRP Patient, Family, and Donor Research Forum, conversations about health in Black communities, patient choice, facts, myths, and fears. So we would like to begin by recognizing that wherever in North America and the Caribbean we are logging in from today, we are located on the traditional territory of Indigenous peoples dating back time immemorial. We acknowledge these lands, the people, and the treaties in place in North America because the first step to reconciliation is recognizing the first peoples of our lands and our relationships and mutual responsibilities. Hundreds of years after the first treaties were signed, these treaties are still in place today. The power and potential of land acknowledgements allow us to connect with the very rich history of these regions and make it clear that there were first peoples who lived on these lands prior to the forced transportation and subsequent enslavement of continental Africans and the related arrival of European settlers. We acknowledge the importance of working in stewardship with Indigenous peoples to manage these lands with respect for Indigenous customs and ways. I am personally based in Hamilton, which is on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. And I encourage you to add where you're joining us from today in the chat. Charles, you can go ahead. You need to unmute.
That would help, wouldn't it? All right, here we go. We acknowledge those who have gone before us. Over centuries, over generations, our African ancestors arrived on Canada's shores and through Canada's ports, some involuntarily and others willingly. Peoples of African descent and continental Africans, as enslaved peoples, as displaced peoples across Africa's diaspora, and as migrants, we have survived. Collectively, we have made an indelible mark. Despite the horrors of the transatlantic slave trade and over 400 years of enslavement, peoples of African descent have contributed to Canada's rich cultural and economic history. We have thrived. In solidarity, as members of Canada's African, Caribbean, and Black communities, we fight against the impact and effects of structural and institutional racism that African continental and diasporic peoples face every day. In so doing, as African descendants, we honor our African ancestors regardless of origin. Thank you all for being here with us today.
Good morning, everyone, or good afternoon for those out east. My name is Patricia McKenzie, and I'm the Executive Director of the Canadian Donation and Transplantation Research Program, or CDTRP. I'm based here at the University of Alberta in Edmonton. I'm a settler on Treaty 6 territory, the traditional lands of the Nehiyot, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe. Thank you, Mary Claire, for delivering the land acknowledgement. Mary Claire is CDTRP's program coordinator, specializing in communications and knowledge mobilization. And thank you very much to Charles Cook for delivering the African ancestral recognition, which was written by Dr. Jacqueline Getfield. Charles is an active member of CDTRP and is an experienced patient partner in health research, lending his experience and perspectives to improve the quality of research and health outcomes for people. So on behalf of CDTRP, thank you for joining us today for the second session in our series, Conversations about Health in Black Communities, presented in conjunction with our 2025 PFD Research Forum. Before we begin, for those who might not be familiar with CDTRP, I want to tell you a little bit about our organization and why we're partnering with CARM to ensure African, Caribbean, and Black voices are engaged in CDTRP's work. So CDTRP is a national research organization now in its 12th year and is committed to improving both living and deceased organ donation and the long-term health of transplant recipients across Canada. We support donation and transplant research by working in partnership with people with lived experience and communities to understand their priorities and co-develop health research and information that matters to them. One of our goals through our partnership with CARM is to build partnerships with patients, families, living donors, donor families, caregivers, individuals with chronic health conditions, and community-based organizations. Together, we aim to work with you, those on the call today, to co-develop research priorities that reflect the needs and experiences of African, Black, and Caribbean Canadians who rely on or may one day rely on donation and transplantation services. At CDTRP, our patient, family, and donor partnerships platform is dedicated to ensuring that the voices and priorities of people with lived experience are meaningfully integrated into all research projects and network activities. We're proud to have over 100 PFD partners representing about 25% of the total membership of our network. And we recognize that their involvement, your involvement, is essential to co-developing impactful and relevant research. And while we're proud of the progress that we have made, we know there's still more that we can do to incorporate voices coming from diverse experiences. So our team, Charles Cook, Manuel Escotto, and Dr. Jacqueline Getfield, is currently in the early stages of developing a patient family donor research advisory group focused on the priorities of African, Caribbean, and Black communities in donation and transplant and regenerative medicine research. And to make this initiative meaningful to the community, I invite all of you to join us and share your insights and leadership on those topics. If you're interested in getting involved, please let us know in the chat or complete the survey at the end of the session, and then we can follow up with you. All right, next up is Istvan, I believe. Over to you to tell us a little bit more about CARM.
Well, welcome everybody. Thank you very much for joining us. I'm Istvan Mucci. I'm a transplant nephrologist at the University Health Network in Toronto. And currently, although it looks that I'm talking from outer space, I am located actually in Europe. And there is a bit of an issue with my internet. Hopefully my connection will be stable to let you know a little bit about CARM. And what is CARM? CARM is a program that we started 3 years ago. It is a Caribbean and African regenerative medicine program, which is co-led by Professor Carl James, who is a sociologist professor at York University in Toronto, and myself. We have a number of co-investigators in this project, and Dr. Jackie Getfield is the program director for this. This program has grown from our previous research about access and use of kidney transplantation by patients from racialized communities, with a focus on certain communities, and specifically African, Caribbean, and Black communities who, based on our data and based on data from Canada, have less access to kidney transplant and living donor kidney transplant compared to white patients. And I started this research program about 10 years ago from research and academic interest. As you see, I'm a white clinician. I'm a clinical nephrologist, transplant nephrologist, and obviously my views and understanding of the issues that people from racialized and specifically Black communities face is coming from that perspective. I'm Hungarian originally, and I'm an immigrant to Canada myself. And this probably was some of the reason why I was sensitized to this issue, this inequitable issue, because as clinicians, we think that for many patients who have kidney failure, kidney transplant and living donor transplant is the best treatment, not necessary for everybody, and this will be a discussion today. And we thought that the fact that Black patients have less access to these treatments will need to be explored because this may lead to unfavorable health for these patients. And from this research, we started to expand into all kinds of cutting edge research based medical treatments, which is covered by the term regenerative medicine. And this program wants to build a dialogue between African, Caribbean, and Black communities and research and clinician communities to better understand how we see major health issues like kidney disease, like sickle cell disease, and how we see the different treatments that are available for that. And we'll try to bring this information about these advanced treatments to the communities with community engagement strategies, and bring back the community's questions, concerns, and perceptions to the research communities so they have a better understanding of the issues Black communities and Black patients specifically face. Another important aspect of CARM is that we want to support young people, students who want to consider medicine and research as a career goal. And in CARM, together with Dr. Getfield, and the co-investigators and Professor James, we have now about 20 or even more than 20 students, some of them medical students, some of them are undergraduate students who help us with this effort. And hopefully they will carry forward the knowledge and understanding from these discussions. And part of our community outreach and engagement, we partnered with CDTRP, as Patricia mentioned, and we try to build on each other's work to reach as many people in these communities as we can, and also to better understand how they see and feel their own conditions and some of the conditions that will lead to kidney disease. So not only kidney disease and kidney failure, but high blood pressure, diabetes, and others. So that's what we do with CARM. And I'm very much looking forward to hear from Patricia and the discussion today about the perspective that she will share with us, with Jackie, and with the audience. Thank you very much.
Thank you, Isvan. So you are in space and I'm on the beach. And where I like to be. So thank you everyone for attending today's webinar. First, I know I've thanked her often, but I'm gonna thank Patricia. I cannot thank you enough, Patricia, for agreeing to participate in today's webinar. You see, not every day we get a chance to hear from our patients. I just came from the patients forum, the first part of it, and that first hour was enlightening to hear from patients, from donors, from recipients themselves. But today we hear from Patricia, and what makes her different, we are going to find out. So whether you are a student, a doctor, a nurse, a specialist, a sub-specialist, whether you are a patient, meaning donor, recipient, whether you're a family member providing care or support, regardless of your role, there is so much that I believe we all can learn from Patricia. So again, I say, Patricia, thank you. So let me introduce Patricia to you. Patricia is a Black mother, a grandmother, a sister, an auntie, and a friend to many. She was born in Jamaica and immigrated to Canada, I believe in her teens. And she continues to navigate a very eventful life here in Ontario. She's here today, as I mentioned, to share her story. She has survived cancer, and she'll be giving us her perspectives on treatment options for kidney disease. People, Patricia has been on dialysis for 21 years. No, just a personal note, because, you know, we must be transparent. I have known Patricia since we both had tiny waistlines and ample hips. Yes. I have known Patricia since we had lots of natural hair and we didn't know what to do with all that natural hair. When Patricia and I first met, we had phones that were not yet smart. They had lines. In fact, we had party lines, and I can't even explain that to you. But you also had cords that would attach the phones to the walls. The phones were not that smart, not like they are today. You could actually, you could actually imagine it only by watching Fred Flintstone and those kinds of cartoons. What would really be the future like? Well, here we are now with smartphones where we can talk with someone and see them and see their surroundings. Or we can block off their surroundings with backgrounds and pictures so you cannot see their smartphones. Futuristic thinking, but is it really? So let me get into it. Patricia, in Ontario, say I'm gonna say good afternoon. I'm gonna say how you do.
Afternoon. I'm good.
What a go on, girl.
I'm just here.
Good, good. We are at a webinar hosted by CDTRP, which is a research organization that focuses on organ transplantation. Now, Patricia, you are neither a donor nor a recipient of any organ. Yet, here you are, speaking to an audience of researchers and students and clinicians and doctors, health professionals, community members, regular people like me. Why is your story important? Why are you here? Give us a little bit of it, because, we'll proceed and ask many questions after this. But overall, why is your story important for this group?
First, I must say that dialysis is not the end of your life. My story is really different. I choose to be on dialysis and not to get a transplant. Due to my background with high blood pressure, and I was offered a kidney because my daughter and I are a match. But then when I really think it through, we on both sides of the family, we have high blood pressure and diabetes. So I decided that I would not accept that kidney.
Okay, so now let us start from even before you became mom and had a daughter old enough to, lovingly offer you a kidney. Let us start from the beginning. I understand that you were a sickly child in Jamaica.
Yes.
What was happening then? How did this sickness present itself? And how did your family respond to your symptoms?
I was diagnosed with asthma. As a young child, every month I would have this fever. And my parents will call it dengue fever. This child have dengue fever. They do their little bush and, give you a bath and, whatever medication was available at the time, just, for the fever. It was after I realized it wasn't a fever. In my late 20s, I realized it wasn't a fever. It was my toxin that mimics a fever. So
let me ask you this. I don't want you to get into the 20s yet. Let me stay a little bit longer. What did the family doctor say? Why did the family doctor think it was asthma? And that led to your family trying to help you by giving you bush tea, by bathing you in different kinds of concoctions. What was the family doctor in Jamaica saying? Why
It was,
asthma?
they just referred, it's asthma. I had the wheezing on my chest, as, most asthmatic. So they just refer it to asthma and that, but every month I will have this fever.
Asthma
So
with fever. Okay.
it's just asthma with fever and she have a
Okay.
cold. Yes.
I
So it
see.
was just that. There was
Okay.
nothing else. And then to the point that, you get a little puffer and that was it. The Ventolin puffer.
Okay. Thank
Then,
you. Thank
yeah.
you. So now, is it your family who decided why Canada? Why did you leave Jamaica for Canada? With whom did you leave Jamaica for Canada and at what age?
I left Jamaica when I was 21. And as everybody leave for a better life, came to family member, and the story goes on and on.
Hey, so you left as an adult. You were not a kid when you
Yes.
left. You
No.
were on your own. You lived with family. What happened next? What happened? What was the oh moment or the Lord of mercy moment? What happened in Canada that resulted in a different diagnosis from asthma? Take us through that.
Went to I actually, my body was feeling a bit off, like weak, energy was low, whatever. And my sister was visiting from Germany and we were out. And she said, "Why are you standing? The store is going to close. Keep walking." And to me, I felt as if I was walking fast, but she said, "You're still standing." And then she said, "Something is not right. Let's go see your family doctor." So I went. They did some, blood tests and whatever. So I really needed to use the restroom. But when I go there, I had that urgency. But when I go, there was no pee. So I told the doctor that, and she said, "Okay." Did what I had to do, went back home. They will call in case of anything. Got the phone call about maybe about 8 o'clock that night. "Could you go to the emerge?" So knowing me, I said, "Why am I going to the emerge?" They say, "You might not make it through the night. You have kidney failure. Your kidney is failing and you need to be there." So I went. My pressure was out of control. So they tried to stabilize that, and it took a while before it was stabilized. And then they say I should go back. I have to see the specialist, which they did all the appointments and everything. So they when they did the test, they test for other stuff, lupus, sickle cells, whatever. And then there they go. They did a X-ray. And when they looked, they saw two little dots where the kidneys were supposed to be. That's how they know that those are the kidneys. They were all shrink. The doctor said to me, I remember clearly that the kidneys looks like a woman of, about age 99. Those kidneys were like down to nothing. And then here we had to, start pulling
All right.
together. Mhm.
So tell me something. Kidneys down to nothing. You had two little itsy bitsy
Yeah,
images. But why
images.
at that point were you introduced to the concept to organ transplantation as a as an option, or was it because the two kidneys were that much compromised that that wasn't even an option? What was going on? What did they say at that point about kidney transplantation, organ transplantation?
To be honest with you, the transplant was never mentioned at that time, but they went in action about treatment, telling me that it's not the end of your life. There are treatments and different types of treatment.
And what were these? What were the ones
It
suggested?
was PD, the one that you do from the stomach, which is the one that they really offer first. The hemodialysis that I'm on now, which is the blood, it's cleansing the blood and returning it back to the body. That would be the last resort. Because if that fails, then we need to come up with an action, a donor.
Okay. And I ask this question because that now would lead us into the conversation that you had with your daughter, or the consideration that you had when you said you thought about it and you figured you would not want your daughter, even though she was a match, you would not want her to donate a kidney. So does this mean that you at some point considered organ transplantation, live donation, kidney from your daughter? Or did you even think, okay, I don't want to get it from my daughter, let me get it from a deceased donor instead? And take me through your thinking, because it is not every day you meet someone who has been on dialysis for 21 years. So my question really is, at any time, and yes, you considered it, tell me about those considerations about organ transplantation.
Okay. To be honest, at first, I thought everything was going to be over with me being on dialysis. When you first hear, you have to be on dialysis. So after being on dialysis, and I was a bit stable and, feeling like my old self. And when the thought came up and with my doctor, and my eldest daughter says she will get tested, which she did. And, it was a hard thing as a mother, saying I didn't want to be selfish, knowing that on her side of the family, both diabetes and high blood pressure. And I think, what if something was supposed to go wrong?
With whom?
With my
And when?
daughter. With my daughter, who would she rely on? So I decide, if I'm on dialysis now and I'm still alive, yes, I do have setbacks, and, but I'm always coming through the setbacks, getting over it. I said, you know what? I'm not going to take it.
Not going to take what?
I will not do the transplant, and I would not accept a kidney from my daughter.
Mhm. All right. So you're not going to accept the kidney. You have decided to continue with dialysis. But as you said, there are up days, there are down days, there are problems.
Yeah.
Tell us a little bit about that. Tell us a little bit about the negative days. And I say that because as far as I have heard, I almost never hear about the positives of dialysis because it is usually taken for granted that dialysis is good for you. Dialysis is the default treatment for diabetes, people suffering, living with diabetes, and people suffering from kidney disease. Dialysis is what I've always known since Jamaica, here in Canada, everywhere. What is not so known is organ transplantation. So I guess it's like talking about air or oxygen. We take for granted air, clean air, until it's not. We take for granted that we are breathing in, we're breathing out, we're living, until the air is compromised by smoke or smog or intense humidity. So that's why I'm asking. Talk to us about the negatives of dialysis. What, even though you're experiencing these ups and downs, these, problems here or there, what are these problems? And therefore lead us into how have you been able to stay, above water? How have you been able to live, to enjoy life with these negatives?
The negative part about dialysis, there are days that you just don't feel good. You will go to dialysis feeling good, being on the machine for 4 hours, and there are things that do happen. At times, your pressure will drop so low that you can't even recognize where you are. And there's something that sometimes you get real dry because they're trying to take out the toxin, and you're being on dialysis, you're not able to pee anymore, so you don't pee. So that's how dialysis comes in, to filter all those toxin and whatever. So sometimes you don't have all that fluid to remove, and they are removing it. So now your whole body is in pain. And when I say I don't wish it on my enemy, I don't. Your body is, I'm telling you, it's a cramp that I've heard patient screaming, passing out from it. Just can't deal with the pain. But I've had it twice in 21 years. I have had that situation twice.
What is this? What is this situation? And does these two intense medical, I would call them crises, that cause people to scream out in pain and your body to feel like it's dried out? What does that do for your other organs? And what do you do when you are in these crises? What is done? What do the doctors do? What do the nurses do?
Well,
Is it an emergency situation?
Yeah. So for me, when I am at the stage of passing out, you have to know yourself. So being on it for 21 years, I understand my body, and I know. So when I'm at that point, I need oxygen, and I need my chair to be low at the ground level,
Your head to be low or the entire bed to be low?
My entire body, head to be low, and while they are administering the oxygen, and that's what keeps me for the other, maybe the next 2 hours or next hour and a half until I get off the machine. However, they have medication that you can take to keep your pressure up, and it doesn't work for me. So then again, I don't take that medication. Like, it doesn't do anything for me. So there are crises that one goes through being on dialysis. I remember days that I lie there and there, I know I can hear them calling me Patricia, 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 but I can't answer.
Are you unconscious?
Yes, I'm at the point of going. But I can hear they calling, no, Patricia, no, no, don't do this. You can't go, stay with us, and they're running up and down doing everything just, to keep things afloat. And in the midst of that, I'm a strong believer of my faith. So in the midst of that, I can hear what's going on. So I know that they're doing the best that they know how, what they're trained for. But in the midst of that, I have to be praying. So yeah.
Prayer comes in because you're a woman of faith.
Yes, I am.
Right. And so you're trusting in a higher being to carry everybody through, you through, and for the medical staff to be given divine knowledge to bring you where you need to be, I would imagine. Coincidences. Do you believe in coincidences? You've had such an eventful life with significant health challenges. There are so many things to touch on. But talk to me about your medical professionals, your doctor here, your nephrologist. Have there been times when you have not been able to afford treatments, either because of financial reasons or because of, I guess, complications with other diagnoses, whether related or not to your kidney disease? Because I can well imagine that with dialysis, it's not just your kidneys that get compromised. Because if you're going through these crises, then other organs may be compromised. But what does that look like? What really does that level of care look like? And what does it cost? And what is this? Who is your nephrologist? Not necessarily his name, but what does he say? What kind of conversations does he have with you to prepare for all these diseases?
Wow. It's a team of doctors, but there's one special one that's the head of the unit. And how I love him. He is someone we can talk to. He listens. He makes plans. One occasion, I was very sick, and the other doctors that was running the unit at the time, the dialysis unit, and I kept complaining, but they didn't say anything wrong. So I called a certain doctor. That's my special doctor. Dr. T. And he said, okay, what's going on? Told him, say, well, take a picture, send it to me, send it to him, say, oh my gosh, girl, you know it. How did you know that was the situation? I said, I just know it had to be that.
What is
Said,
the
okay,
situation?
I had built up calcium. And he said, okay, we have to get that treated. And it's not covered by OIP, not covered by the government. And the treatment is $1,000 per treatment. And I do dialysis 3 days a week. So each treatment, it would be $1,000. So it would be $3,000 for the week. And I am there saying to myself, I said, I can't afford it. So what's next? I was there, the social worker, I was admitted in the hospital. The social worker came, she talked to me, and she said, Dr. T won't be here for the weekend. And there is a doctor across the border that is very interested into your situation.
You mean in the US? When you say across the
Yes, yes, in the US.
border?
And I said, okay. They said, but you have to sign some documents. He wants to learn more about what's going on with you and, see where they could come together and help. So knowing the type of person I am, I started asking questions. I said, how did this doctor know about me? And she was trying to tell me and trying not to say anything at the same time, and said, just work with us. So I signed the paper, and whatever they said, they will get back to me. Haven't heard anything from them over the weekend. But when Dr. T returned on Monday, he spoke to me, how you doing? He came, check up on me, whatever. But on Tuesday, I got a phone call saying, tell your youngest daughter to come down to my office and collect your medication.
So this is Dr. T, or was it
Yes,
the second in command at the unit? This is Dr.
you're
T.
right. So I'm saying, oh, he left on the weekend, came back on Monday, then by Tuesday, pick up the medication. So something wasn't adding up, but I leave it alone.
Yes, because you are there to drink the milk, not count the cow.
Yes, exactly. So I just leave it alone. And, my daughter, she went and picked it up. And then he called me, did you get it? Yes. You're going to take it to the hospital and your dialysis stay. And a special nurse will come and collect them from you. And it was years after I got sick again, but the same thing.
The calcium build up.
Yes. And he said to me, when I left on the weekend, where did you think I went? He said it takes 7 months for it to be cleared at custom.
Oh, for the medication?
Yes. Since most of the time, patients are dying, they need it. So a family member will have to go to the States, get it, and I'm just going to use the term, and try to smuggle it in. Because they cannot wait on the time frame that they have. The patient have a time frame, and being at the border before they can clear it, they have a time frame. So most of the time, that's what they do. So he said, remember once I joked with you and I said, do you have any family member in the States that would,
Okay, so he facilitated you get this medication in a timely manner so that it could be beneficial to you.
Yes.
So when you said you took a picture of your body part, was that your foot?
My foot.
And that is where it showed the effects of the buildup of the calcium.
Right.
And
So
that is the situation that the medication was going to address.
Yes.
Okay. So that now brings me, so congratulations. You have a wonderful relationship with your doctor.
Beautiful, beautiful.
Not many patients can say this. So I have two questions, and I don't know which is more important, but as you're speaking, it occurs to me that not many Black patients would have a story such as this. In fact, you hear the opposite, that they experience racism in the health care system. They don't have access to treatments. They sometimes are not even told about certain treatments. Forget medication that is so rare that you have to literally smuggle it into this country. They don't even have the option because they don't know about it. So the question is, have you experienced racism in Canada in the healthcare system since you have been going through all these varying levels of treatments?
Yes.
What does that look like? How does that play out in your life?
It doesn't feel good. It doesn't look good. But with my
Give
faith,
me an example. Give me an
for
example.
once, I remember when I had my amputation and I was in the hospital, and at that time, everything was out of whack. And I was on this floor, and the charge nurse, she was white, and her team was mostly white. And just the way she handled patients, and I was caught up in it too. You know, if I wouldn't call and ask for help, because you would be there and waiting and waiting and waiting. But she realized about Dr. T that he was always coming to visit. So I think in her mind, who is this person? Who she thinks she is? Why is she so special? Because he would come up on the floor with, with two of his team. They would say, "Hi, Patricia, how everything is going? Do you need anything? How you feeling today? Did you get up? Did anyone come and walk you? Try to get up and try to stand on the other leg, because he would go above and beyond." And, I would say no. And then he will go to the front desk and he will just raise a ruckus about it. So there it comes back to me.
What comes back to you?
Like, if I would buzz, nobody will come. And I'm not a buzzer. But if I do buzz, once she is working, that special head nurse, she wouldn't come. So I realized there was something going on. I try not to butt heads with her, so I try to avoid her as long as I was being admitted. I tried to avoid her, not ask for anything. And there were one and two nurses, so they in her mind she would think, oh, she wait to when Dr. T is there, and then all the complaints go to him, which it
Oh,
wasn't so. But because he's there, he see, did you eat this morning? Did you get up this morning? Did someone help you this morning? Or whatever. They're busy. Um, and I will just tell him, oh, the nurse says she's busy, she will get to me, whatever, and but
So let me ask,
I,
let me ask you this. When you are a patient, and in this case, you said you were dealing with your amputation, and how important is it for you to have a doctor who not only knows your health situation, but knows you well enough and is willing to advocate on your behalf? Because I'm thinking that is rare, but that cannot even be quantified, the importance of that. So tell me about the amputation. How did the amputation come about? Because you said you had previous calcium buildup,
yeah.
and you talked about the amputation. But what happened between the buildup when you got the medication, and what precipitated, what caused the conversation about amputation? Because it sounds to me as though there were doctors and nurses who did not necessarily realize that you were having calcium buildup. You
No,
figured it out that one time, then you got the medication. So what happened between that time and when you actually were you told that you should amputate? What happened for you to decide to amputate?
um, to be honest, I kept, looking at my foot. It was a summer was over. And I remember I said to my daughter, doesn't my left foot look darker than the right foot? And she said, yes, mom, but summer just finished. All you wore was the sandals. I started getting like real bad cramps and my foot would go numb. So complaining to the doctor, I said, this doesn't feel good. It hurts. And oh, I look, your foot is warm. It feels good. You're not diabetic and whatever. So that's when I call in Dr. T again. He looks, he said, okay, we're going to keep our eye on it. And I'm going to get another doctor to look at it, and we'll take it from there. Looked at it, Patricia, it's warm and I can see a little discoloration, but we're going to do a close swatch and that foot. So, okay. I was in and out of the hospital. The pain was severe.
For
It
how
was
long?
severe.
For how long? How long were you in
It
and
was
out?
from the February until the April. I was in and out with the pain. And so there they start administering morphine. Morphine would just take the edge off and I would sleep, wake up, the pain is there. So it was like every 4 hours morphine, every 4 hours morphine. So I was always drugged up. Morphine, morphine, morphine. The pain was severe. So I remember, they had a pain management team came in and I was wearing the patch. I was taking the pill. I was getting the drip. It was horrible. And there was this Jamaican Chinese doctor. He came in and he said, Patricia, this is just to make you comfortable, but it's not good. They're all of this medication is killing you. And I don't feel good about it. So something have to be done. I'm going to take away some of this morphine from you. So him say, I'm going to start with, X, Y, and Z first. And I said, okay. And I remember days I'm there and I know I'm at dialysis, but I just felt lost. And I remember Dr. T came in doing his rounds, and the nurse pulled him aside and said, something is going on with Patricia. And he said, I know. She's extremely quiet. And the nurse said, not only that, when I speak to her, she don't answer back, she don't reply, she's just staring. And I don't know if she's understanding, but something is not right. And he said, okay, he's going to get in touch with the pain meds team again and see what's going on, what else they can do. And he said to me, don't give up. And I was just staring at him. And he walked away. I went home, but before going home, but by the time I went downstairs, I don't remember where I live. Can't remember my taxi number. And the volunteer, she said, I know you don't want to be admitted. I know you hate the hospital. But she said, I can't just have you here. And she said, you can't remember? And I was just staring at her.
So you are going through you're having brain issues as well. You're getting confused.
Right.
So
I
then,
was getting, and at that time, they realized my body was septic. So that's what's causing all the confusion.
when you got to the hospital, that's when they realized that you were
Yes.
becoming septic. Okay.
So
you got to the hospital, and then what
I
happened?
got to the hospital. As a matter of fact, I called Dr. Ting and he said, oh, what a coincidence. I was just going to call you. And
Another coincidence.
yes, so get in touch with your daughters and any other family member, and we need to have a meeting at the hospital today, now. So I said, okay. He said, why were you calling me? And I said, Dr. T, I know you have my best interests at heart at all times, but I think it's time. It seems a time to do what? I said, I want to remove my leg.
So it wasn't he who suggested it, it's you told him.
Yes, I told him it was time. So him say, okay. Him say, it's a coincidence. That's what I wanted to talk about. So I said, okay, I'm on my way. And my daughter drove me. We went and they were crying. We were in a room. And I remember the whole situation. My cousin Michelle was there. And, I say, I'm ready. So he called the nurse, said, could you start some pain meds and whatever, please? So in my self, I said, oh, yes, I'm going to remove the foot today. And I was happy. And then Friday come. This was a Thursday. Friday come, nothing. Saturday, my pain ceased. And I said, what is going on? No, I'm going to have the surgery on a Sunday, which was hard, they said, but I don't know why it was done on a Sunday. So I couldn't wait. Sunday morning, they prepped me and everything, and we went down. All day Saturday, no pain, nothing. So I started to question myself, saying, what if I'm running ahead of myself and this is not what God wants for me? And I just started praying. because I didn't want to run ahead of myself and do it. Come on, to make that decision, to amputate your leg, it's not no ball in the park. So while I was there and they were prepping me and the nurses and the doctors were in a room talking and whatever, I said, God, I want you to show up for me now, not tomorrow, not next week. Now I need, I need an answer. I need a sign. And there and then that pain came rushing and I screamed. The doctors came rushing and said, what happened? Did she fall off the bed? What happened? And they said, we just hear her start screaming. And I just turned and I said, I need this foot to go. I cannot live a next day with it. They say, you sure, Patricia, because we could do it on Wednesday. I said, no, I'm ready now.
And then they did it on Sunday.
And then they did it on Sunday.
At this point, I would like to introduce Dr. Arilon Chrysostom. We call him Dr. Chris. And I want to introduce Dr. Chris to ask him a few questions about what you have just said. Because, of course, for many of us, your story is so incredulous. But we want to hear from Dr. Chris. Before I open up to questions from everyone else, I want to hear from Dr. Chris so that I can get a bit of clarification and the rest of us on this in this webinar. So let me introduce Dr. Chris first. Dr. Arilon Chrysostom is originally from Trinidad and Tobago. He did his medical schooling at the University of the West Indies. I am guessing it's Mona campus. He has served as specialist in Montserrat in the Caribbean, and he has a passion for kidney disease. This led to his fellowship in nephrology, and he's currently pursuing a kidney transplant fellowship at the University Health Network in Toronto. Dr. Chris has said that he likes to play the steel pan and the piano. And he, of course, he stays active as all kidney doctors should. And he loves spending quality time with his family and friends. Dr. Chris, good afternoon.
Good afternoon, and thanks for having me.
We are so happy that you're here because I have a few questions for you. And one of them, the first one I'll start off with is Jamaica. Because you were trained there, you served in the Caribbean. Still befuddled about asthma, a diagnosis of asthma. How did that come about? How did a diagnosis of asthma come about from a doctor when maybe 15 years later or so, it is a diagnosis of kidney disease? When the kidneys are so atrophied, what's going on there? What is the difference? And I'm asking this question because there may be medical professionals who are on the line or may hear this webinar, the recording of the webinar, and I want them to understand that when they see a patient in front of them, it's important to know the positionality of the patient. It's important to know what obtains in the countries that these patients are from that form and influence these patients' lived experiences with healthcare. So in Patricia's case, I'm asking you, you are a doctor some 20, maybe 30 years later. Nonetheless, you're a doctor who was, was trained there. What happened? What happened? Take us.
That's a very open-ended question, simply from the perspective that it's easy to they usually say hindsight is 20/20, right? It's easy to say that, things were missed or things could have been overlooked 20 years later, but uh, I unfortunately did not have the benefit of doing like my own history and examination, which is usually critical to making a diagnosis of asthma. In addition, there's usually a criteria that should be met when you are diagnosing asthma, and there are a gamut of tests or investigations that you would have to do prior to saying that someone indeed has asthma. So what what the doctor at the time may have seen may have been shortness of breath. Shortness of breath has a very wide differential, and there are a number of things that can cause it. But sometimes if you oversimplify the symptoms or what the person may be experiencing, you may just think, oh, you're short of breath, you probably have asthma. You have asthma in your family? All right, well, let's treat it for asthma, which really may not be the case, and there maybe a lot more underlying um, issues that need further investigation or further teasing out. So to say that the diagnosis was asthma, I am still not thoroughly convinced that that is exactly what it was. Um,
Mm.
because the issue of you said that well, she said that when she did the investigations, and Miss McKenzie, I thank you for sharing that story. It was really, well, your story. Uh, it was a bit too relatable, to be honest, because I have heard a number of patients speak. A lot of them sound very similar to how you have, aired your story. But I'm speaking to the aspect of the kidney being small or shrunken. The unfortunate thing is in the Caribbean, we don't really have adequate screening for kidney disease. So the the scenario that presents itself oftentimes is you would find out that you have uh, a very advanced kidney disease or end-stage kidney disease. End-stage kidney disease is when the kidneys are so advanced that you would need some form of renal replacement, which is like dialysis, as we discussed, the peritoneal as well as the hemodialysis or transplant. Now, usually when you get to that stage, because there's inadequate screening, sometimes things would end up being missed. So in other words, you would have hypertension, but is the hypertension causing the kidney damage, or is the kidney damage leading to hypertension? Both scenarios could in fact be true. And when you pick it up at a stage where there's scarring and there's so much kidney damage that you don't know exactly what caused the kidney damage, you end up saying that, oh, it was probably hypertension, but we don't know whether this underlying problem was brewing for some time. It remained indolent, and then when it finally showed its head, it manifested as hypertension. So that is something that in the Caribbean we are often faced with, and it's often difficult to determine what is the underlying cause, because even when we look at the Caribbean data from the Caribbean Renal Registry, the most common cause of kidney disease stated in that registry is hypertension. Now, that is the case simply because, one, it could be true. We have a predominance of high blood pressure in the Caribbean. We also have a predominance of diabetes. And worldwide, the prevalence is diabetes. But with a scenario that I just described, where screening is not as good as it should be, you may get some cases where they present with high blood pressure, but the actual problem may not have started as high blood pressure. So, then in speaking to the two issues, yeah, we are not convinced that it was in fact asthma. It could have been something else. And then the hypertension, we're not sure if it was due to a kidney problem that we just picked up late, or if it was actually due to high blood pressure damaging the kidneys over time.
All right, so let me circle back around to the matter of the oxygen when there are crises. Because in my non-medical head, I hear asthma, I hear lack of oxygen. I understand that when there were crises, two major crises, during dialysis treatment, that Patricia says she needed oxygen rather than, or she chose oxygen rather than medication to basically stabilize herself. That's what I
Right.
heard. And
Right.
so what does that look like? And what does that lack of oxygen, how serious is this? And what does that lack of oxygen do to the other organs that are maybe compromised, or are they compromised? Or maybe I'm just overreacting. What's going on there?
Well, definitely not an overreaction. If we usually use a pulse oximeter, or the thing that you put on your finger to measure your oxygen levels. It was very popular during the COVID time. So when we check the oxygen levels and they are low, low is very relative, but normal is usually above like 94%. So if they are low, there are a number of things that can cause it. But the most common issues would probably be one, a lung issue or a heart issue. And if the lungs are not, if the lungs are not exchanging carbon dioxide and oxygen well, so that your blood is being oxygenated, as they say, then that could cause the levels to go low. So if you have a lung issue, and a lung issue it doesn't have to be primarily a lung issue. It could be the fact that you have fluid in the lungs, or the the pipes that lead to the lungs, or the bronchioles, or the bronchus. Those could be constricted, as is the case in asthma. Or you could have a heart issue, and the heart is not pumping blood around the body well. Therefore, the oxygen levels progressively fall as the heart fails. So if you have heart failure and your blood pressure goes very low during dialysis, it may manifest as, the oxygen levels may fall as a result as well. So the oxygen levels, if you are receiving oxygen therapy, because oxygen, believe it or not, is actually a drug, just like other medications. It's just something that we need to survive, but it is a drug if given in excessive amounts. So if you require a large amount of oxygen in order to maintain circulation, in order to survive, quote unquote, then it speaks to the fact that something is actually going on in terms of the lungs or in terms of the heart. And most patients on dialysis, when you've been on dialysis for a long time, you have an element of heart disease. It's usually a coronary artery disease, because the same processes that are occurring in all the blood vessels, including in the kidneys, are also occurring at the level of the heart. So it could have been, well, due to a heart issue, could have been a lung issue, but the more common one is that there's a heart issue.
Okay. So here is my final question for you with respect to Patricia, and then you can ask Patricia any question, I guess, that you would, and then we open it up to everybody. In terms, because again, why is Patricia McKenzie here at a CDTRP event where really we normally hear about organ transplantation? And one of the reasons why we invited Patricia to speak is because we want healthcare professionals, family members, caregivers to consider that each patient has the right to make up their own mind and to choose for themselves the treatment option that works best for them. They have to live with it. So what we want is for healthcare professionals, doctors, subspecialists, to take into account the ideas of who really is the patient, the positionality of the patient. How are these patients positioned? Where are they from? You know, the intersecting identities, meaning the patient's race, the patient's class, the patient's abilities or disabilities, and how these all come together to influence who this patient is, and therefore what kind of treatment that this patient really needs. And not just treatment as in the medical, but as Patricia had said, her doctor knows her so well that he goes beyond the medical and the clinical to speak to who she really is and what she really needs as a person. So when patients migrate from other countries, when they immigrate to Canada, you as a doctor who know you have been doctoring in both Canada and in the Caribbean, what are your thoughts? If somebody were to say, what are the 3 top considerations that you believe your peers, your professional peers should take into consideration, what would these be? When
Well,
dealing with you know, patients who hail from elsewhere?
okay, good question. I would in if I had to give the top 3, number 1 would be cultural context. When it pertains to choosing like a dialysis modality, for example. Number 2 would be trust, level of trust. Um, and number 3 would be just knowledge base. So cultural context, trust, and knowledge base. So in terms of cultural context, uh, in the Caribbean, or should I say Jamaica in particular, uh, kidney transplant is not something that is widely spoken of. It's something that you hear that has happened from time to time. So there isn't an infrastructure put in place where we could actively and on a continual basis provide this service to patients all year round. For example, here at UHN, there's an average, I mean, before coming to UHN, I read that, you know, this is one of the largest transplant centers in North America. And actually being here, I realized that a slow week, you may just have 2 or 3 transplants for that week.
Wow.
While in Jamaica, there would be persons that, well, you would hear that there are 2 or 3 persons being transplanted for the year. So it's a great disparity in terms of the uh, seeing kidney transplant as a working reality for a Jamaican patient, right? In addition, the the taboo around transplant, it's there are some cultural norms. You would hear people say, no, I don't want nobody taking my organ. I want to, if I have to die, I want to die whole. Nobody would take piece of my organ and do this and do that. We don't know where they come from. So there's a whole taboo as it pertains to the whole issue of transplant, which has to be, you know, addressed. So that's the cultural context. The second one is trust. Um, Now, trust is a very broad term, but in essence, trust is the healthcare system is it could tend to fluctuate in terms of providing reliable health care across the board, right? So there would be people that see one hospital as superior or one hospital as being way better than the others, and the other hospitals would be they don't trust the healthcare system so much, right? Um, now this is something that I've recognized based on how patients feel. If they're seriously sick, the Jamaicans in the audience would know they go to UC, right? Which is the university hospital, which is perceived to provide a better standard of care than a peripheral hospital or a hospital run solely by the government, right? So in that context, when it comes to doing a kidney transplant, because there's no infrastructure there and because there's a trust issue, people are generally reluctant because the biggest part of the transplanting service, it's not about the surgery. The surgery is the easy part. It's about the lifelong follow-up and dealing with the complications of immunosuppression and all those things, which people generally are unaware of. And because of the fluctuating standards of care, they may not trust the system, right? So that is one thing that is a factor. The other aspect of trust would be in terms of the doctors, right? So in terms of the number of nephrologists that are in Jamaica, the last time I checked, there were probably about 10 or 11 in total, right? This is to serve a population of around 3 million people whose number one health issues are diabetes and hypertension, which all lead to chronic kidney disease. So there is a shortage of nephrologists, and because of that, there is also each nephrologist is kind of stretched very thin. So you sometimes if you don't know the doctors personally or you get to know them, you would feel as if, or if you don't ask for them to see them specifically, you would feel like you have been ignored or you are being overlooked. So that is where another issue of trust becomes evident. And the third one is the third issue. I remember outlining it. I can't remember what the third one was, but just
So
it was
you're saying to me, let me just jump in here while you try to recollect.
yeah.
To me, I'm wondering if it's a cycle. Is there's a program in these quote unquote first world countries? Transplant is not a strange concept. It's a part of our everyday conversations because it is a part of the everyday realities of mainstream Canada. It would seem to me that organ transplantation is not a part of the everyday conversations of people from the Caribbean, generally speaking, especially the smaller islands in the Caribbean, geographically smaller islands, but also in the larger islands like Trinidad and Tobago, like Jamaica. I don't know what the numbers are in Cuba, but is it a cycle or is it depending on the amount of money that you have? And because you don't have people with a lot of money, then clearly you're not going to have a lot of transplants. Is there a program by the government to a transplant program, if you will, that is backed by funding and research and the rest of it? And I'm asking this question again because when a patient presents with the need for organ transplantation, is that even a conversation? Or is it just, let us not even talk about that because it's not going to come to fruition in the Caribbean?
Well, it's good that you brought that up because the short answer to whether there is infrastructure to support a transplant program, currently, no. That's the short answer. Right now, even to do the kidney transplants, it requires effort where there's liaison with a transplant organization in the UK, and they would actually come to Jamaica and assist with providing the surgeons, providing the transplant nephrologists, and even when there are issues that come up, that the regular or the general nephrologist in Jamaica cannot troubleshoot. It requires a meeting with those transplant nephrologists in the UK via online or as Zoom call or what have you, so that, you know, care of these patients in terms of the follow-up, it is challenging. The government, well, if you lived in Jamaica at any point in time and know of anyone that was on dialysis, we know that these persons fund their own treatments.
And how many per week, roughly?
So,
Because everybody different based upon the amount of money that you have. But
yeah,
what is the typical recommendation versus from the medical professionals versus what is the reality?
yeah, the standard of care is that you do a minimum of 3 times per week dialysis, 3 to 4 hours sessions. However, in Jamaica, I would say 92% of patients, that was the last figure reported, based on the dialysis units across the island, about 92% of them are patients that do dialysis twice a week. So they do it twice a week, mainly for the cost. It's cost limiting. And there are persons that in fact do dialysis once a week. So I always say flippantly that the cause of death from kidney disease is not necessarily end-stage kidney disease, but it is actually poverty in Jamaica, because a lot of these patients die because they have insufficient or inadequate dialysis, they don't have access to care, and over time it just weighs on their body systems.
Okay, thank you so very much, Dr. Chris. We have some questions in the chat, and Devron or MC will be asking these questions. So can you go ahead? Is it question for, and identify if the question is for Patricia or Arilon? Sorry, Dr. Chris. But first, let me ask you this. Do you have any questions for Patricia? Patricia, do you have any questions for Dr. Chris? Let me ask that first before we go to the Q&A. If there are any, you don't have to have questions. No, I'm not putting you on the spot. But if you have any questions for each other, now would be a time to ask them. Or we can jump into the questions in the chat. Devron and MC will read them, and then we can come back to you as you formulate your questions, if you have any. Devron, MC, please go ahead.
Yeah. Sorry, so we have one question in the chat saying, Patricia, thank you for sharing your story. And this person actually has a few questions they want to ask, and highlighting the strength that you've shown over the years. Were there moments when you felt especially unsupported or unseen in the healthcare system? And in these cases, what helped you to keep going? The second question being in your...
No. Let her answer the first question first. Let her answer the first question first.
Yes, I have been there, but as I said before, my faith is what really keeps me. There are times when I'm at my lowest and I feel like no one understands, and I am attached to a prayer group that's run by my sister-in-law. And at times when I'm at dialysis and I'm at my lowest, that's where my anchor holds. That's where I have to call and just ask for prayer, because I need to get home. I want to get home to my grandkids. I want to get home to my kids. I don't want to be admitted. And my faith and my trust in God, that's what keeps me. I can't speak for anyone else, but that's what keeping me. That's what keeps me going. Because as my Dr. T would say, just the other day, he called me and he said, you know, you're a miracle. Everyone that you started dialysis with, they're deceased. And you're still here. And him say, look what, I am calling you for prayer. I'm asking you to pray with me because I'm in a crisis and I need prayer. So it's just my faith that keeps me. And I have a beautiful church that I attend. And my apostle, Apostle Donna Hines, that keeps me in prayer. And, you know, I can go to her, I can talk to her. I'm not feeling well. She say, you know what, you have come a long way and God will never leave you nor forsake you. Say it's basically my faith that keeps me going.
Okay. Next question, Devron. Thank you very much, Patricia, for that.
Thank you. The other part of the question is, so in your experience, how can healthcare providers better support Black patients who are living with chronic conditions like kidney disease or cancer?
I'm sorry, could you repeat that one more time?
Yeah, sorry, I'll go ahead. So in your experience, how can healthcare providers better support Black patients who are living with chronic conditions like kidney disease and cancer?
Okay, in terms of kidney disease, thank you for your question. In terms of kidney disease, I think there just needs to be a bit more awareness as to what kidney disease entails, what the road ahead looks like, because a lot of persons coming from the Caribbean or other countries, they find out for the first time that they are at stage 5 kidney disease or that they need dialysis when they show up with an emergency. And it really is a big shock to them because they had not been prepared from before and they were basically unaware. So I guess we generally have a decreased level of awareness as it pertains to kidney disease and how it progresses, and maybe a conversation surrounding the modalities available to them before actually having to need those modalities to live would provide at least a somewhat of a knowledge base or at least a heads up, as they say, so that we could make better decisions and we could actually be more educated about the condition of kidney disease. As it pertains to cancer, I would leave that to the cancer experts, but just as a physician, generally you have your age appropriate screening, both males and females for the most common types of cancers, being breast cancer, prostate cancer, colorectal cancer, even some blood cancers like multiple myeloma and leukemias, lymphomas. All of those, there are specific guidelines outlined for the age that we should start screening based on your family history. So it would just require following up with your doctor regularly and getting screened for these illnesses so that you're always aware of what's happening in your body.
Thank you for that. Are there any more questions right there or?
We have a few more.
Okay. You have a few more. Okay, go ahead. Because I have a question from Dr. Mucci.
So the other question we have here is, I'm a research student with the Co-Create Lab in Ottawa and a peer equity navigator. Sorry, yeah. So they're curious, and I think they're asking in the Canadian or more specifically the Ontario context, is dialysis fully covered, or do patients have to manage some of the costs for themselves? And that could go to either of you.
It's fully covered.
And by extension, is all the costs associated with organ transplantation fully covered? Is that a consideration? For example, for even you, why you didn't choose it? Let's say if you got a kidney that is not your daughter's kidney, and were you given that kind of information when you were being told about dialysis? Did they tell you about transplantation? Did they go into what the costs are, if any? What did they say? What were you told about transplantation then? And would you consider it now?
I wasn't told at beginning, but later down doing dialysis, I was told about it, but at that time, I don't think there's the cost is the meds, because some of the meds might not be covered by disability. So there you need to have other insurance. It's a lot of meds, right? And I was diagnosed with cancer too. So I was on the waiting list. I should say I was on the waiting list for transplant. And that was during the time with my daughter and everything. And then I was diagnosed with cancer. So I had to be off the waiting list for 5 years. And then I was off, went in remission. They thought it came back. And I just decided, you know what? I don't think the transplant is for me. So I choose to just stay on dialysis.
I see. I see. Are there any other questions in the chat?
Yeah.
Or Q&A, Devron?
Yeah, thank you for that answer. So then the other question, I think it goes back to the discussion you were having previously, but a bit more on this, Patricia. How did the medical team react when you chose not to have the transplant? And in all these years, have they come back to ask you if you've changed your mind?
Dr. T, he was okay with it because he knows that I'm aware and I'm an able-bodied person to understand the outcome of dialysis and, other things. So, yeah, they came to me once and, said, would you consider it? And I said, no, because I've seen patients that they had a transplant and it lasted maybe for a year. One, they still don't know. Her kidney was failing, which is the transplant kidney, and they were trying to save it. So they up her medication, and somehow she came up with cancer, and that was another fight. The kidney did not survive, so she went back on dialysis. No, back on dialysis, dealing with cancer. And she overcome that. Then it came back, went back in remission, came back. And I spoke to her today. She had a stroke and, different things. So I just choose that for me, and I would never discourage anyone. I have a friend, and I think she's online, that she had her kidney transplant, and I think it's 13 years now, which they say it would last for 10, and she has beat the odds. She's on it. She might have a little complication here and there, but her kidney's still functioning. So I choose not to. And I have no regrets.
And we should live our lives that way, and the treatment options are open. Are there any more questions, or can I?
One more.
Go ahead.
Yeah. 3 more to go. So this is the question for Dr. Chris. What motivates you to be actively involved in your patient's care, similar to Patricia's doctor, Dr. T? And how do you manage providing each patient with exceptional care while dealing with so many other patients?
Well, that's a good question. I think what motivates me is just the humanity side of things, the fact that I am or my family members are not immune to sickness or illness, and the same care that I would wish for myself or one of my family members, I would give to someone, because everyone is a family member of someone, and we are not immune to illness. So it's just the humanitarian side of things. It's just part of who you are in a sense. And how do I manage to provide care for all the patients. The truth is, not every patient requires the same amount um, of attention to different illnesses. There are some persons that do well and you just check up on them and make sure they continue to do well. Some persons may be not so well and they may need a little bit more care to get to a state where you can just intermittently see them. So there's a spectrum of, I guess, severities of illness, and each one would require a different approach.
Thank you.
Thank you.
The other question we have here, and this is a question for both. Thank you for the insightful presentation. What steps can the organ donation and transplantation healthcare community take to improve trust in the system and normalize organ transplantation as a treatment option for Black patients? What steps can be taken to build trust and to make organ transplantation a normal treatment option for Black patients?
It is an option, and I've seen Black patients that has gotten transplant. And I think, and it's something, well, where I do dialysis, it's something that is, they have forums that they speak about transplant. So, and it's not just for one set of people, it's for everyone. And both for even the family members are invited to attend the forum. And I think it's a good idea, you know, to speak about the transplant. But a patient should have the opportunity to choose whether they want to go with the transplant or to stay on dialysis. Being on dialysis, it's not an easy road. It's not. It's not. So I would always encourage anyone, if the transplant is something that they're considering, go with it. Because not everyone can deal with doing dialysis. Because what keeps me going is I treat it as my job. So I work 3 days a week and my payment is dialysis. That's what keeps me going. Because there are days I don't want to get up and I don't want to go.
Thank you.
I hear you. I hear you. And that's an interesting way of putting it. That dialysis is your job. Just like how every one of us, there is a reward, there is a return on the energies that we expend and invest. And for you, it is going to dialysis, making up your mind that you're gonna do this thing because you're anticipating results. And there's some who, of course, just as you said, they would prefer to do organ transplantation, but they can't. For whatever reason, they don't have access to organ transplantation. They don't qualify. They don't have a match. They don't have a kidney. They don't have a family member willing to donate a kidney into the system. For so many reasons, some people, and especially Black persons, don't have a match because the numbers are low. I think it's 1% or a little bit over 1% of persons who actually have a, I'm sorry, go ahead.
And also being on the waiting list.
What about
That's
that?
another thing, you know, it's like, I think it's 7 years.
Wow.
So, yeah. So I've known patient waiting and they pass.
Okay.
So, yeah. And I've seen it on both sides of the fence, whether you're Black, whether you're Asian, whatever. But I mostly see, to be honest, the Asian people, they pull together, they work together. So a lot of them do get the transplant. My
And you
friend
know,
got
because you're located over in Scarborough, so you have
right. Yes,
vantage point to understand those communities.
right. And one of my friends, she got her transplant through a lottery.
A lottery. Okay.
Yeah, they have it, and it's just a live donor that decide to give a kidney to anyone. They don't know who they're giving it to, and your name go into that pile, and they pull the name out. Her name came up.
Wow.
Yeah,
Interesting. Interesting.
and she was on the waiting list for, I think, maybe 4 years, 5 years most,
I
and
see.
she got it. Yeah.
Okay. Dr. Mucci, are you able to connect with us? And do you have a question for Patricia or a response regarding the waiting list or anything of any of the above?
Well, I hope the connection is stable. Thank you very much for this fascinating discussion and sharing your stories. For Chris, for your meaningful response, and also telling us about what's happening in Jamaica, and it's important for us to know what are the circumstances in other countries where our patients are coming from, whether they come early or late, still they carry that kind of background with them, and as you say, the positionality. I have a few points, just kind of to reiterate some of that was mentioned. So early on, there was this discussion about asthma or kidney disease, and as Chris mentioned, we don't quite know what exactly happened. What the important point is, and it could be that Patricia had both an asthma type of illness and separately something that attacked the kidney eventually. What is important to know, and we also emphasize whenever we talk about these things, that kidney disease itself usually doesn't have any symptoms. And as Chris mentioned, you will only know if you screen for it. And especially if you know or suspect that you may be at risk for kidney disease, either a family member had kidney disease before, you have high blood pressure, you have diabetes or other, then screening should be done. And screening is done with blood work and testing urine for protein. And that can be done early or can be done as things go on. And then hopefully that would result in finding that kidney disease earlier when your kidneys are still normal size, not as tiny as Patricia's kidneys were when she was diagnosed. And when you find this early, there might be things that you can do. And increasingly, we have more and more things that we can do with kidney disease to slow down the progression and potentially prevent kidney failure. When it becomes kidney failure and you need a treatment, as it was mentioned, the treatment, the kidney replacement treatment could be either transplant or dialysis. So it's not that you need to do dialysis first and you can only do transplant after. You could potentially do transplant first without even going on dialysis.
Dialysis.
But for that, you need a donor, you need a potential living donor at that point early on. And as it was discussed, it's important to recognize that not everybody can have a transplant and not everybody wants a transplant. Uh, and this can change because you may want a transplant, you wait on the waiting list, and then you have developed cancer. If you have cancer, you cannot have a transplant. But if you recover from the cancer, then you can be again a candidate for transplant if you want it. But this is kind of something that is an important thing to keep in mind. And these conversations, it's not a decision once and forever that right now I don't want. 5 years later, it may change. Or right now I cannot have for whatever reason. Again, a few years later, it may change. So that is important to keep an open mind. But for people who don't want and cannot have a transplant, good dialysis, and this is also important what Chris mentioned, that if you do dialysis, it's important that you do it well, you get enough, because dialysis cannot give you too much kidney function. The more you do, the long-term impact, the long-term benefit from dialysis is better. And although you may feel unwell immediately after or during dialysis, but if you still do it enough, long term, it will help to maintain your health as much as possible. Kidney transplant, if it's successful, it gives more kidney function and kidney and blood clearance and cleaning than dialysis. But again, it's not necessary for everybody. And I think it's really these are the points I wanted to make, and I wanted to thank both Patricia and Chris for their sharing and very important contributions.
Thank you very much, Dr. Mucci. Are there any more questions? Because if not, I'm going to invite Manuel and to give the closing. So going once, going twice. Are there any more questions? No. Devron, MC? No.
No more questions.
Before I invite
Maybe I just jump on. It's not a question, but also Chris mentioned, and one thing is important, that people know about all these things. So that's why we have these conversations. But also, I just wanted to point out that the CARM program has its website. It's carmnetworks.ca, and then we might put it in the chat. And Devron also added the kidneyhealthacb.ca website, which is a kidney health education website designed and maintained by the CARM team, in keeping African, Caribbean, and Black patients in mind.
Wonderful. They say great minds think alike. Somewhere deep, deep down inside, I must be a transplant nephrologist, because that is exactly what I was going to say. That having no more questions, we just put in the chat that, those two websites are there. So yes, I know I am a transplant nephrologist somewhere deep inside, very deep. So at this point, I would like to introduce Manuel Escoto. He is the Patient Family Donor Partnership and Knowledge Mobilization Director. Let me say it again, the Patient Family Donor Partnerships and Knowledge Mobilization Director at the Canadian Donation and Transplantation Research Program. We call it CDTRP for short. And we almost never talk about his position title because it's just too long. So Manuel, please come and tell the audience members about the conference that's happening right now. I caught an hour of it before, and it's fabulous hearing patients talk about the role that they play in research, or the role that they think they should be allowed to play, the greater role in research. It was a very rich conversation. And I invite everyone here who wants to learn more about becoming more involved in research to click on the links that MC and Devon will put in the chat, so you can join the Patient Family Donor forum that's going on now. So without further ado, and only because we have 5 minutes left, Manuel.
Excellent.
Please come.
Yes, thank you, Dr. Getfield. We love our long titles and we love our acronyms. So thank you for that. I know it's a tongue twister, as they say, but really just start off by saying thank you everybody for joining. Of course, everybody who participated on the conversation today. Dr. Mucci for your expertise, Dr. Chris for the wonderful contributions, Dr. Getfield for your excellent moderating skills, and of course Patricia for sharing this story and your experience. It's hard. Sometimes it can be hard to express what you've gone through, and a lot of pieces. So as I said earlier, or as I said in the first part of the PFD forum, I myself am a transplant recipient, 18 years, and hearing a lot of what you said really resonated with some of my experience. I think one of the pieces that really I was like, yes, like you've got it there, is when you said your own body. When I was on dialysis, I also experienced those crashes, so to speak, when your blood pressure that goes too high or too low, and your own body, and recognizing those symptoms. So thank you for joining us today.